Hello, I'm Eric Strong, and I'm a clinical associate professor of medicine at Stanford University. Today, I'm continuing this series on the respiratory system with some basic respiratory physiology to introduce some concepts that will get much deeper dives later in this series. In this video, you will also start to see how different concepts and topics that superficially seem separated into anatomy versus histology versus physiology are actually all interconnected. By the end of this video, you'll be able to describe the changes in pressures and volumes that occur during the respiratory cycle, describe VQ matching, describe the process of gas exchange at the alveolar level, list the normal partial pressures of O2 and CO2 in the air spaces and blood vessels, and define the AA gradient. In short, I'll be starting with how air gets into the lungs, once in the lungs, how it gets to the location of pulmonary blood flow, and once air and blood are in close proximity, how individual gas molecules move from one to the other. I'll start with the mechanics of the respiratory cycle, that is, the sequence of events that occur from the onset of one inspiration to the conclusion of the subsequent expiration. If you've already studied the cardiovascular system, this diagram, called the Wigger's diagram, may already look familiar. It shows the sequence of events occurring in one cardiac cycle, consisting of the beginning of one systole to the end of the subsequent diastole, in which intracardiac pressures and volumes are graphed alongside each other as functions of time. We can do the same thing with the respiratory cycle during quiet breathing at rest, although it doesn't have an eponym or formal name. By convention, it usually has the lung volume measured in liters on the top of the diagram and a graph of two pressures measured in units of centimeters of water on the bottom. One pressure is that within the alveoli, and the other is the pressure within the pleural space. The numerical values of the pressure are relative to atmospheric pressure, which is why they are sometimes negative. At the transition from normal expiration to inspiration, the volume of the lungs is sitting around 2.0 liters or so, depending on the age and sex of the individual. Alveolar pressure is at zero relative to the external environment. If it wasn't, air would be actively moving, so the pressure has to be zero at the moment of transition, just as it will be zero at the moment that inspiration transitions to expiration. The pleural pressure will always be negative compared to atmospheric pressure, which is essential because this negative pressure pulls outward on the lungs, preventing their internal elastic recoil from causing lung collapse, a potentially catastrophic problem without immediate medical intervention. Inspiration is initiated by contraction of the diaphragm and other respiratory muscles, which pulls the parietal pleura outward, generating an increase in the magnitude of negative pleural pressure. This causes the lungs to expand, naturally leading to an increase in lung volume. As with any gas, as the volume increases, the pressure decreases, so the alveolar pressure initially decreases relative to the external environment. This creates a pressure gradient which draws in the external air. As air moves into the lungs to occupy the increased volume, the alveolar pressure approaches back to zero. Expiration is triggered by relaxation of the diaphragm, with the rapid increase in pleural pressure to a less negative value, which allows the internal elastic recoil of the lungs to increase alveolar pressure slightly above zero relative to the external environment, squeezing out the additional volume that had been gained during inspiration. Note that under normal conditions, expiration lasts longer than inspiration, and most of the volume of air expelled during expiration is expelled relatively early. The difference in lung volume between end expiration and end inspiration during normal comfortable breathing is called the tidal volume. One final point with the diagram is that the difference between the alveolar and pleural pressures at any given time is called the transpulmonary pressure. Since the pleural pressure is more negative than alveolar pressure, under normal conditions, the transpulmonary pressure will always be a positive value. It is the principal determinant maintaining lung inflation. Now that we've seen a tiny taste of respiratory mechanics that is, the process by which the lungs exchange air with the outside environment during inspiration and expiration, let's move to the next step of how that inspired air is brought into close proximity to the blood of the pulmonary capillaries. As discussed in the video on the histology of the respiratory system, gas exchange in the lungs occurs across the ultra-thin alveolar capillary membrane, consisting of type 1 pneumocytes, the capillary endothelium, and a fused basement membrane sandwiched in between them. But the process of gas exchange is complicated by the fact that not all parts of the lung receive equal ventilation, and not all parts of the lung receive equal blood flow, also called perfusion. The major contributor to regional differences in ventilation and perfusion is gravity. Let's look at ventilation first. In the upright lung, there is a gravity-dependent pleural pressure gradient such that the pleural pressure is more negative at the apex than at the base, pulling more outwardly on the alveoli at the apex. As a result, apical alveoli are more distended at end expiration. Alveolar compliance, which is the property that determines how much they change volume in response to a change of pressure, is dependent on how distended they are at that moment. Relatively distended alveoli are relatively less compliant, meaning they resist changes in volume. It's analogous to how a balloon is increasingly difficult to further inflate as it approaches its maximum volume. As a consequence, during inspiration, the apical alveoli expand relatively less as compared to basal alveoli, meaning more ventilation occurs at the bases. In other words, even though the apices are more inflated than the bases, because they stay more inflated throughout the respiratory cycle, there's less exchange of fresh air. For perfusion, there is also a gravity-dependent gradient of hydrostatic pressure within the pulmonary vasculature. So as with ventilation, there is also more blood flow at the base compared to the apex. The intrinsic architecture of the pulmonary vasculature also plays a role in the preferential flow of blood to the bases. Critically, however, when comparing regional differences in ventilation and perfusion, there is a smaller difference between ventilation at the apices versus the bases than there is a difference between perfusion at the apices versus the bases. Let's see what this looks like when we graph regional differences in ventilation and perfusion alongside each other. We can see that the matching of ventilation to perfusion is not uniform throughout the lungs. There is relatively more perfusion compared to ventilation at the bases, and relatively more ventilation compared to perfusion at the apices. One can quantify this matching with a number called the VQ ratio, in which V stands for ventilation, and Q unexpectedly stands for perfusion. In more formal contexts, these letters have dots over them to denote that they are time derivatives of the values, that is, changes in volume per unit time, or flows. The VQ ratio is relatively high in the apices, meaning there is wasted ventilation within the distal air spaces there that either do not participate in gas exchange at all or contribute to a less than ideal degree. The volume of ventilation that is wasted in this way is called the alveolar dead space, not to be confused with the anatomic dead space of the conducting airways. Conversely, the VQ ratio is relatively low at the bases, meaning that some blood passes the alveolar capillary membrane without complete oxygenation, which can lower the oxygen in blood returning to the left side of the heart. As mentioned, the VQ ratio can be quantified. The maximum VQ ratio in the apices of healthy lungs is usually reported as 3.0, while the minimum in the bases is usually reported as 0.6, though these values are age-dependent. When a weighted average is measured across all lung units, the VQ ratio in a healthy lung is approximately 0.8, consistent with alveolar ventilation of about 4 liters of air per minute and a cardiac output of about 5 liters of blood per minute. A mismatch between ventilation and perfusion exists even in healthy individuals, but the lung has an important intrinsic compensatory mechanism to limit it: hypoxic pulmonary vasoconstriction. When alveoli are poorly ventilated and the partial pressure of oxygen in the alveoli is low, the surrounding pulmonary arterioles constrict, diverting blood flow towards better ventilated regions. This helps to optimize VQ matching, particularly in the setting of pathology. Hypoxic vasoconstriction is unique to the pulmonary circulation. Systemic arterioles, in contrast, generally vasodilate in response to local hypoxia. But even with hypoxic pulmonary vasoconstriction, some degree of VQ mismatch still occurs. This normal amount of VQ mismatch is relevant to the alveolar arterial gradient, more commonly called the AA gradient, a concept which was introduced in the video on lung anatomy. To remind you, the AA gradient is a difference between the partial pressure of oxygen in the alveoli and that in the systemic arteries, carrying oxygenated blood to the rest of the body. There are two main contributions to the normal AA gradient. First is imperfect VQ matching, as just mentioned, and second are small anatomic shunts of blood that bypass the pulmonary capillaries, including part of the bronchial circulation that supplies oxygen to the tissue of the conducting airways. So, even in ideal circumstances, with completely healthy lungs, the blood leaving the lungs remains less than perfectly oxygenated. Although some degree of VQ mismatch is always present, in clinical medicine, the term VQ mismatch refers to pathologic conditions in which the ratio of ventilation to perfusion deviates significantly from normal. VQ mismatch is the most common general mechanism of hypoxemia. VQ matching will be discussed a lot more later in this video series. Now, let's look at how gas exchange works at the level of a single idealized alveolar duct, alveolus, and pulmonary capillary. Here's a simplified schematic of these structures. The now space in between the alveolus and capillary is the very important alveolar capillary membrane, across which individual gas molecules move down their respective concentration gradients via passive diffusion. I'll be showing some partial pressures of gases in various spaces. These numbers represent the ideal conditions in healthy lungs at sea level in a hypothetical prototypical alveolus. The actual specific values in real lungs varies between the bases and apices. As you may recall from high school science, the total pressure of a mixed gas is the sum of the partial pressures of the individual gases. At sea level, total atmospheric pressure is 760 millimeters of mercury. Of this 760, if the air is dry, that is, not humidified at all, the partial pressure of oxygen is 159 millimeters of mercury. That of carbon dioxide is low enough to approximate as zero, and dry air has no water vapor. If you're wondering where the other 600 millimeters of mercury of pressure comes from, remember that atmospheric air is mostly nitrogen gas, or N2. Nitrogen gas is biochemically inert and plays no significant direct role in human physiology outside of undersea diving, so we can ignore it for now. As air enters the body during inhalation, it encounters the very moist airways and becomes saturated with water vapor before reaching the alveoli. At normal body temperature at sea level, the consequence of humidification is a partial pressure of oxygen in the alveoli of around 100 and a partial pressure of water of 47. In addition, there's now carbon dioxide present that has diffused outward from the blood and normally has a value in the alveoli of around 40. You may notice that for these values, I'm now using approximately equal symbols. That's because different references report slight differences in these values depending on which simplifying assumptions are being made in their measurements and calculations. For example, for the partial pressures of alveolar oxygen, references cite ranges of 99 to 104, with 100 being the most commonly cited number. However, 100 being the most common is just as likely due to it being a nice, round, easy-to-remember number than because it's the most accurate. A quick note about notation: when discussing respiratory physiology, the partial pressure of a gas in the alveoli is represented by a capital A, while the partial pressure of a gas in the arteries is represented by a lowercase a. In colloquial speech, we typically refer to P big AO2 versus P little AO2. If someone states just PaO2 without a big or little qualifier, it's implied to be P little AO2. Let's take a look at what happens to individual molecules of gas. Both O2 and CO2 are returning to the lungs via the pulmonary artery. Although this blood is referred to as deoxygenated, it's not completely devoid of oxygen. Normal PVO2 is about 40 millimeters of mercury, in which the V stands for venous or mixed venous, the latter meaning venous blood from all parts of the body that's been thoroughly mixed in the right side of the heart. Normal PVCO2 is about 45. As the capillary blood moves past the alveoli, the pressure gradients drive oxygen from the alveoli into the capillary and drive carbon dioxide from the capillary into the alveoli. The consequence is a normal PaO2 of 100 and PaCO2 of 40. It can be a little confusing that the venous partial pressures are from the pulmonary arteries, while the arterial partial pressures are referring to the blood in the pulmonary veins. This is because the PV and Paa are referring to the systemic veins and systemic arteries. Also, these precise numbers are idealized. When actually measured in patients, there is a normal range. For example, PaO2 is 80 to 100, with older patients tending to have values on the lower side. Normal PaCO2 ranges from 35 to 45. A few things to notice here. First, expiration of relatively CO2-rich air and inspiration of CO2-devoid air is responsible for getting CO2 out of the body, but the process is kind of slow in the sense that during inspiration and expiration, only a fraction of gas within each individual alveoli is exchanged. You might think that this makes gas exchange less efficient, but it actually protects against problems that would be caused by wide moment-to-moment swings in your blood's O2 and CO2 content that would occur if the gas in the alveoli turned over more rapidly. Second, if the patient is breathing in air that is either dry or with any humidity less than 100%, there will be a net movement of water vapor out of the lungs. Breathing literally dehydrates us. This water loss is not usually clinically significant in healthy individuals engaged in normal daily activities, but becomes so in the presence of high ventilation rates or in the presence of critical illness. Third, and most importantly, while there is usually no significant difference between P big A CO2 and P little a CO2, there is always at least a small difference between P big A O2 and P little a O2. This difference is the A gradient I mentioned earlier. The magnitude of the A gradient is important in determining the underlying cause of hypoxemia. P little AO2 can be directly measured via an arterial blood gas, which is a blood test run on arterial blood rather than venous. However, P big AO2 cannot be measured directly and must be calculated using the alveolar gas equation. Do not worry about the details of this equation right now. Both the alveolar gas equation and how we determine the normal A gradient for an individual patient will be covered in a future video. Time for a summary. Inspiration is driven by diaphragmatic contraction, which generates more negative pleural pressure, expanding the lungs and drawing in air. Expiration during quiet breathing is passive, driven by elastic recoil. Transpulmonary pressure is quantitatively equal to alveolar pressure minus pleural pressure. It is always positive under normal conditions and is the principal determinant of lung inflation. Ventilation and perfusion are gravity dependent. Both are greater at the lung bases than the apices in the upright position, but the gradient is steeper for perfusion than for ventilation. The VQ ratio quantifies the matching of ventilation to perfusion. The normal weighted average is approximately 0.8. The ratio is higher at the apices, where it's about 3.0, and lower at the bases, where it's about 0.6. Hypoxic pulmonary vasoconstriction is an intrinsic compensatory mechanism that diverts blood away from poorly ventilated alveoli, optimizing VQ matching. The AA gradient is a difference between alveolar and arterial partial pressures of oxygen. It is normally small, but non-zero due to physiologic VQ mismatch and small anatomic shunts. Pathologic VQ mismatch is the most common general mechanism of hypoxemia in clinical medicine. And last, you will need to remember some of the normal partial pressures of gases at sea level. These include P big AO2 of about 100, PVO2 of about 35 to 40, PVCO2 of about 40 to 50, PaO2, that is P little AO2, of about 80 to 100, and PaCO2 of about 35 to 45. That concludes this introduction to a few basic concepts in respiratory physiology. Later videos in this series will do deeper dives into more specific individual physiology topics with a focus on the relevance to clinical medicine.